Hello, everyone. Thank you for standing by, and welcome to Caring for Baby Skin, sponsored by IsisParenting and MD Moms, and presented by Dr. J.J. Levenstein. My name is Cindy Meltzer. I'm the Director of Community and Social Media here at ISIS, and I'll be your moderator this evening. During the presentation, all participants will be in a listen-only mode. However, you may submit questions to the speaker at any time by typing them through the chat feature located to the left of your screen. We'll take questions at the end of the presentation. Today's webinar is being recorded, and all of you will receive a link to the recording early next week. So if you miss something or need to step away to tend to your baby, that's okay. Okay, so let's just take a second to talk about IsisParenting. IsisParenting is proud to host this evening's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at IsisParenting.com. And then let's talk a little bit about MD Moms. Let me tell you a little bit about our co-sponsor for this presentation, MD Moms. The MD Moms are Dr. J.J. Levenstein, yes, who is our presenter this evening, and Dr. Diane Trong. They were inspired by the needs of their patients and their own children to create Baby Silk, the first pediatrician-developed personal care line for babies. Drawing upon their experience, expertise, and the latest medical data, they strive to provide babies and their parents with the most innovative, luxurious, effective, gentle, thoughtfully developed products on the market. MD Moms products are naturally based yet scientifically advanced, using only the purest, highest quality food grade and pharmaceutical grade ingredients. Every formula is clinically tested, rated hypoallergenic, and suitable for even the youngest baby's uniquely delicate skin. As I mentioned, I'm Cindy Meltzer, and I am your moderator this evening. And it's my pleasure to introduce our presenter for this evening, Dr. J.J. Levenstein. She spent the last quarter of a century caring for children. She received undergraduate degrees from UC Berkeley and Duke University and completed training as a physician assistant with a specialty in pediatrics at Norwalk Hospital, Yale University. She received her medical degree from the Keck School of Medicine at USC and completed her pediatric internship and residency at Children's Hospital of Los Angeles. Today, Dr. JJ has a thriving private practice in Southern California. She is a fellow of the American Academy of Pediatrics and serves on the clinical staff of 2 hospitals. Welcome, Dr. JJ.
Good evening, everybody. It's sunny in LA. I'm just sorry it's probably cold where you are.
Yeah, it is, but that's okay.
Yeah, it is. I kind of like the weather. I miss it back there. So, but it certainly is a season where we see lots of things happening in kids' skin. So hopefully tonight we can shed some light on what may be going on with your little ones and give you a little primer on how skin behaves and what it does. And we have a little technical glitch tonight, so I will be doing the old-fashioned thing and asking Cindy to move my slides along as I need them, so bear with us.
Which I am more than happy to do.
Thank you so much, my humble assistant. Well, one of the things that we see in practice so much, probably one of the biggest questions we have on a daily basis, has to do with skin. It is the largest organ in the human body. And in babies, it actually, for pound of body weight, has more square inches than it does in adults. So it really is a very large and very important organ, especially in our wee ones. As they are aging, their immune system grows up, but when they're babies, their immune system is very immature, and so skin really is that first line of defense, while the inside of the body is building up its natural defenses. So taking care of it and maintaining its integrity is very paramount in these early days. As a result of its delicacy as well, there are so many things that can happen to skin in the early days that kids eventually do outgrow, and so those are a relieving thought to parents who are suffering along with their children with problems in these early days. Cindy, can I have the next slide, please? Okay, so a little anatomy lesson here. It's a little bit of a busy slide, but skin is composed of 3 layers. The topmost layer that we all see called the epidermis, the dermis, which is the layer underneath, and then the subcutaneous tissue, which is the deepest layer. On this slide on your left, that's a picture of thick skin. So that would be like the skin on our palms or soles. It is hairless. You see a thicker cushion of fat, which is the yellow layer deep down below. A few blood vessels, but not much in the way of hair or sweat glands. And on the right, the very busy skin there, much thinner. This is skin with hair. And so skin that has hair is typically on our face, on our scalp, obviously, our extremities, and all those parts of our skin that are more exposed to the environment than those that are covered with shoes or with clothing. So you can imagine that with all these hair glands, oil glands, sweat glands, immune glands, muscles that control goose flesh, etc., that our thin skin actually has a lot more going on, and therefore maintaining its integrity is very, very important because it serves so many functions. The epidermis, which is the beige and purple layer that you see, has no blood vessels. And in fact, skin cells migrate up to the top of the epidermis and sort of check out their inside. So their cytoplasm or all their organ or their cellular function is lost, and so just the remnants of the skin cells are in the epidermis, and so they don't need a blood supply, and they eventually shed. So we all know what dandruff feels like. We all know what it's like to shed your skin after you have a baby, and even after a sunburn. So that is the epidermis. Below in the dermis is where all the action happens, and this is where so much regulation occurs. This is sort of nature's cushion. Within the dermis, we have the nerves of sensation, we have hair follicles, we have sweat and oil glands, we have blood vessels and lymphatic vessels, which filter and clean any little invaders that get through the epidermis. And then the hypodermis down below is a fatty layer, and on thin skin there's not much fat, but it is an area of cushioning. It gives us skin contours, it gives us cheeks and dimples and all sorts of roundness that make us appealing as humans. Can I have the next slide, please? So just to give you a broad overview, skin serves multiple functions. It is necessary for our immune defense. It maintains hydration by giving us sort of a wetsuit, in essence, keeps us from evaporating too much fluid off. It's responsible for sensation and touch, and we all know what a great massage feels like, or the sensation of our baby's skin against ours, and to lose that is to lose a whole lot of humanity. We also know that skin is responsible for manufacturing vitamin D, and because vitamin D doesn't come over breast milk to any great degree, skin is essential for our bone health and for our structural strength. Skin stores fats and water, and again, these are necessary for the skin remaining intact, supple, and soft. And skin is water resistant, so we don't fill up with water when our skin barriers are intact. Temperature regulation, as you all are aware, I'm flushed and red here, and you're all probably sitting with a bit of goose flesh going outside today, so we have little muscles within our skin that help us hold temperature in, or when we have fevers or we're overheated, skin lets that heat out so that we don't overheat. And our skin also just guards and hides our underlying structures and organs so we don't look like that invisible man model that we all put together in grammar school. Next slide. So again, the unique qualities of infant and baby skin. Babies have more skin per pound of body weight than we do, so therefore that function is just so important. We went over regulation of temperature and the defense system of local immunity that the skin provides. And because our thin, hairy skin is that area that's exposed more to the environment than our thicker skin, then infant and baby skin is more prone to damage from everything ranging from ultraviolet rays, even on cold days, to chemicals, even effects of food allergy that creates eczema and rashes. And certainly just in looking at those layers of skin, anything can go wrong along the pathway from hypodermis to epidermis. And we'll explain a lot of the common conditions we see in babies. Next slide. So I'm going to go over some typical eruptions and rashes in the first year of life, and I've actually had a chance to look at a lot of your questions that you so thoughtfully presented tonight, and I'm happy to say that we'll probably be able to answer those within my talk, and then any other ones that come up later we'll get to. This is actually a really cute baby, by the way. All right, first slide, please. Okay, so you're in the hospital. You pick up that beautiful hospital-grade T-shirt, and on the first or second day of life, you might see something like this on your baby and wonder what just happened. Well, this is a typical newborn rash called erythema toxicum. Means toxic red rash in Latin, but it is far from toxic. We don't really know what the cause of this is. It's merely an adjustment rash. So if you imagine that a baby goes from the waterborne environment of the womb to the outside world, which is dry and scratchy, the skin makes an immunologic adjustment that may last up to 3 to 4 weeks. So these look like little bug bites. They may be yellowish or blistery looking. They kind of migrate, so you pick up the shirt and 5 minutes later it's gone there, but it's appeared in another part of the body. They sometimes can be quite dense and quite red and a little scary to new parents, but they come and go without leaving scarring. We just leave them alone, and it doesn't arouse much worry once you know that it's normative. And so the more you know, knowledge is power. And in this case, erythema toxicum just means your baby is adjusting normally, and that just validates that baby skin is reacting correctly. Next one. Next slide, please. Now, peeling. I don't know if you've all seen James Bond movies, but in the old days, Sean Connery would come out of the ocean in a wetsuit. He'd unzip, and he'd have a beautiful tuxedo underneath and ready to go to a cocktail party. Well, in babies, I kind of look at their first coating of skin as that wetsuit. Within a couple of weeks of being out in this environment, they sort of unzip their skin, they lose it, and underneath is that delicate, beautiful pink baby skin that you all were hoping and wishing for. Peeling on baby skin is unavoidable, and it occurs to varying degrees. Usually starts way out at the edges of the baby where their little LoJack from the hospital is, so their ankles and wrists, where they wear all the little hospital jewelry, tend to start to peel first. But by 2 weeks of age, they sort of look like a little gecko molting, and they peel off all the skin, and it's painless. There's no way of staving it off or stopping it. For some babies who have extreme peeling, they may get what are called little fissures in their skin and little cracks like we would have on our hands on a very dry day. And so sometimes application of a bland ointment or lotion on those little very dry areas may make a baby a little bit more comfortable, but quite honestly, you don't have to put anything on the skin, and we just let this process happen. When would you worry that peeling represented something else? If it was preceded by big blisters like you would find on your heel after putting on new ski boots. If you saw big blisters like that followed by peeling of that blister, then baby may have a staph infection, and especially in areas where there may be application of Vaseline or petrolatum, for example, after a circumcision. If there's too much occlusive ointment on a freshly healing wound, a staph infection can occur. So if you ever saw a big blister followed by some peeling, it certainly would be something to bring to your doctor's attention. If you had chickenpox in the last several days of your pregnancy before delivery and then baby came up with some blisters, that would certainly be a reason to bring to your doctor's attention, but they'd probably be all over it by then anyway. And there are some rare genetic skin conditions where babies sometimes develop blisters all over their body and then eventually peel. But again, your healthcare team would be all over those rare scenarios, and presuming you're all healthy today, hopefully none of you have had to face that kind of challenge. Next slide. Baby acne. Okay, so enough of it when we were teenagers, then we get some of this when we're pregnant, and then our baby comes out, and they're almost picture perfect, opening their eyes, starting to smile, and all of a sudden they break out with some zits. Usually around 1 month of age when they start to be alert and darling, they are sometimes not so picture perfect. Now, why does this happen? There are a couple of theories. One is that some of the hormone load that comes over the last bit of pregnancy may stir up a little dust in the sebaceous glands and the oil glands of a baby. But others theorize, and I kind of agree with this, that babies go through a little mini puberty, usually around 3 to 6 weeks of age, where there's a final organization of their little ovaries or testicles, and then the ovaries and testicles go into hibernation until puberty. During that time, there are nice spikes of testosterone and estrogen, and those hormones are responsible for organizing and putting our baby's little futures into hibernation, but they also can stimulate hormonally responsive tissue. And one of the biggest hormonally responsive tissues is our skin. So the oil and sebaceous glands go into overdrive, and suddenly your baby has these little red-based zit-like lesions on the cheeks. They rarely go beyond the face, and they pretty much resemble what we might have had as teenagers. The worst thing we can do is squeeze them, of course, and not only as teenagers but also babies, because we do incur the risk of infection and also scarring down the line. There are some babies who have such aggravated acne that they can scar, and again, this is a rare scenario, so given that we have a lot of health care checks in those first 2 months, if your provider or doctor feel that the acne in the baby is more severe than what would be the norm, they may prescribe a little topical benzoyl peroxide, believe it or not, or a topical antibiotic for the baby. But generally speaking, all you have to do is keep the baby's skin clean, and as he or she is burping breast milk or formula or drooling on their cheeks, just wiping it off with a clean washcloth or cotton ball and washing the face a couple of times a day is just enough to keep the skin clean while this process self-resolves. And usually these are gone by the second month or 10 to 12 weeks. So that's baby acne in a nutshell. Next slide, please. Now, what is often confusing is that the oil glands and sebaceous glands not only can get turned on to create acne, but also can create this other mess called seborrhoeic dermatitis. On the head, it's called cradle cap, and that picture on the left is pretty representative of a moderately severe case, and on the right is seborrhoeic dermatitis that's across the eyebrows of that baby and on the cheeks probably, and my guess would be behind his ears. This stands apart from infant acne because it has a yellowish, scaly, greasy appearance, usually on a red base, and if you ran your hand across your baby's skin, it would feel very rough and dry. Your baby at this point may also be rubbing their head against their sheet on the crib or against you, because older kids who have seborrhoeic dermatitis say that it itches and bothers them. So if the baby's a little fussy and seems to be rubbing off these big scales, dollars to donuts, you've probably got a little seborrheic dermatitis. The good news here is that there's actually something that can be done about this particular eruption. Now, in mild cases, you can just let it go away. It can self-resolve, no problem. But sometimes we get such an overwhelming collection of scale that it's not only unsightly, but if left to its own devices, especially on the scalp, can cause some temporary baldness if the scales get very thick and sort of usurp the territory of the scalp hair. So what's a mother to do or a dad to do? I think if you're brave enough, it's reasonable to just take a thin washcloth that has some nap on it, or even like a 4x4 gauze, and after washing your baby's hair, just giving it a little bit of friction over the areas of scale, and then literally with your fingers or with a soft toothbrush or with a little comb, you can comb out the scales. Hard part here is that soft spot's in the way, and with tons of folklore and a lot of concerned relatives around, it may be a little hard to wrap your arms around putting any pressure over the soft spot, and that's typically, of course, where cradle cap occurs. So sometimes just using one of the cradle cap preparations that are out there is reasonable. There are various ones. Most of them are emulsions of oils, and some have what are called exfoliating agents in them. Our particular one has a little salicylic acid in it, so we soften the scales with the oils, and then the salicylic acid will cleave the bonds of the cells so that they're very easy to wipe off or brush off. So help is out there, and it's just a matter of how brave you are as far as rubbing the scales off and how meticulous you are. But the good news is all babies do outgrow this phase. Again, it seems to be linked to hormonal events, and they're temporary, and so cradle cap and seborrhea generally are gone by a year of age, and they may kind of come and go for a few rounds, but they do eventually go away. Next slide, please. Okay, milia. Now, milia, some of you may have as adults. These are little white bumps, sometimes around the eyes in adults, but in babies they occur as sort of flat, white, speckled appearance, generally in the folds of the nose, sometimes around the eyes, but they tend to be centered around the mid-face. In the transition from the wet environment to the outside dry environment after childbirth, what happens is that keratin, which is the empty cells that are in the epidermis, forms these sort of nodules or little plugs, and they plug up the pores of the skin. So these are really just sort of protein plugs. Some people think that they may have some sebaceous material, oil, with them as well. They're white, and they don't smell, they don't itch, they don't have any symptoms, and they generally will just sort of naturally exfoliate over the 80 to 120-day life cycle of human skin. So again, left to your own devices, they'll go away in babies. Now, when babies are older, if they have them around the eyes, or if older children or young adults have them, sometimes dermatologists will prick them and express the contents of those little nodules. And certainly when you've had facials, you've had somebody come at you with a tiny little loop and get rid of some of these little keratin plugs. That's the strategy in older individuals, but in babies we can leave these alone, and generally they'll resolve on their own and leave no scarring behind. Next slide. Diaper rash. Okay, this is a hot topic, literally. This poor baby bottom that you see here is a more severe case of diaper rash, and the combination of pee and poop in a diaper is a chemical one on occasion, and so the chemical called ammonia, which we have smelled before in smelling salts, but also in diapers, can scorch this delicate little area down here. And although this is hairless skin that's supposed to be tougher, the diaper area is particularly prone to developing eruptions, only because it's warm and moist, and it's sort of a little sauna and petri dish for all kinds of insults to happen to baby skin. So urine and feces definitely interact to create ammonia. The moist environment promotes bacterial growth, and because we don't like babies' diaper contents to fall to the outside world because it's a big hot mess, lack of airflow, we tighten those Pampers and put those nice little G-diaper covers over our cloth diapers, and we don't have a very nice aerated environment. So those are all the sort of risk factors that generally will make our babies prone to diaper rash. When diapers aren't changed frequently, especially poopy diapers, when a baby sits in that chemical reaction, certainly that is more of a risk factor. If the diaper area isn't given a breather, i.e. if it's super hot, super moist inside the diaper, the baby's wearing plastic pants or non-breathable diaper covers, or if they just don't get their bottom open to air very often, then again, little bugs grow and rashes propagate pretty quickly. In the early days, in the first 2 months or so, when a baby's breastfeeding or even bottle feeding, we know that little ones make 12 to 16 stools a day on occasion, and just when you think you've got that diaper area dry, they're pooping again. So that frustration and just the liquid nature of the stools spreading in the diaper can often present a challenge. And in those early days when baby skin is so thin and so delicate, they don't have much of a bumper back there to handle insult, and rashes and rawness seem to be a common part of our early days in parenting. Diarrhea, of course, is a big risk factor, and so if a baby has a viral based diarrhea, or if they have diarrhea from introducing new foods that don't agree with their stool, or they're adjusting to a new formula, or they're on antibiotics, or a mom who's breastfeeding is on antibiotics, they can have diarrhea for many reasons, and the pH or acid content of the stool can contribute to diaper rash. Food sensitivity certainly can be paramount, not only in something that baby may be eating, but also what mom is eating if she's breastfeeding. The presence of antibiotics, both in breast milk and also in the baby's gut, can do this. And sensitivities even to a new diaper brand or to a topical agent that's used on the baby, whether it's something you're bathing the baby in, whether it's a diaper cream, or just something that the baby rubs up against. All those have been known to cause diaper rashes. Next slide. So how do you prevent these bad boys from happening? Frequent diaper changes are really the name of the game, especially with the poopy diapers. So if you hear that little gas rumble coming out of your baby as they're feeding, whisk that diaper off and actually clean the area around the bottom with either cotton balls or a little washcloth or a wipey before you put the diaper on. Now for urination diapers, because if you're using disposable diapers, they're so absorbent. Often you don't have to go through a big cleaning ritual with pee diapers, but certainly with poo diapers, cleansing the skin reasonably after each diaper change is a good idea. And if baby skin looks like it's turning a little bit red or starting to break down, then using a bland ointment or diaper cream are advised. The hard part for me in practice is that when a parent comes in with a complaint of diaper rash, and I open the diaper and I see 20% zinc oxide on this baby, trying to take that spackle off is very painful for a child, and although zinc at high percentages is a great barrier, if a child's skin is broken down and they have a diaper rash, it's very hard to take off and it's very painful to put on. So trying to identify either a dimethicone-based or ointment-based diaper cream to use when your baby has a diaper rash is kinder, gentler on them, and it's easier for your healthcare provider to also remove it so that we can see underneath and see what's going on. If your baby can have some air out time on their bottom too, whether they're napping, if you can put either a plastic liner underneath their sheet or just double up a beach towel and let them sleep with their bottom open to air when they're taking their frequent naps during the day. Often that will make the difference between a bottom that dries up quickly and a bottom that stays sort of hot and bothered. Using thinner diaper creams, as I mentioned before, and an old NICU trick, which is taking either liquid Maalox or Mylanta, putting it on cotton balls, and applying it onto the bottom that's scorched. It neutralizes the skin. It doesn't need to be taken off. It's great when you have a little heartburn as a parent too, but it serves a little double duty. Those are really easy interventions that are very, very accessible. And if your baby has diarrhea, using probiotics with your doctor's okay for your baby is a reasonable thing, and especially if your baby's on antibiotics or you are on antibiotics, making sure the baby gets a little probiotics to kind of counteract the changing chemistry of the gut if it's being messed with antibiotics. Next slide, please. All right. This little bottom is a real unhappy one and probably very itchy as well. It probably makes you all cringe just looking at it, so you can look away now. This is a yeast diaper rash. It's caused by a common skin fungus that lives on all of us in small amounts but overgrows under certain conditions. So yeast can overgrow in the diaper area when it's hot and bothered and airless. So on hot summer days when that diaper is like a little sauna, yeast can overgrow and flourish in those conditions. If a baby's on antibiotics or mom is on antibiotics, the good bacteria on the skin are kind of knocked down to smaller counts, and yeast can overgrow and overthrow the government and in those conditions. And so you can get this very, very red kind of coalescent rash, as you see there, and the dots around them are called satellite lesions. And in older babies, you'll see their hands down in their diapers, hugely trying to scratch those areas. And in younger babies, they might be very irritable with every diaper change. Every time you touch that area, every time they pee or poop over that skin, you might see them really fuss. So if you see a rash that looks like this, typically your pediatrician would recommend clotrimazole, which is also known as Lotrimin in a brand name. It's an antifungal cream that's readily available over the counter. And typically you can use Lotrimin 2 or 3 times a day to settle down these rashes. Now, the other thing that can happen is that if a baby has oral thrush is candida or yeast that overgrows in the mouth. It's a common occurrence. Sometimes when nipples break and crack when babies are breastfeeding, mom's yeast feeds on that breast milk and overgrows on the nipple and then plays a game of ping pong back and forth with baby's mouth. So if baby opens up their mouth to cry and you see this sort of white, cottony, speckled eruption on the inside of the cheeks, over the gums, on the tongue and the back of the throat, then that yeast can also be swallowed, go down the digestive tract, and end up in the diaper area. So if you see a diaper area looking like that, make sure you take a look in your baby's mouth. And if it looks white or cottony, make sure that your doctor takes a peek, because then the intervention might be a little bit more aggressive with giving baby either some oral antifungal medication to take or some swish and swab medication for baby, and also for some topical medication for your nipples if you're breastfeeding. If you're bottle feeding and baby has oral thrush, then nipples, bottles, pacifiers, anything that goes in the baby's mouth should be put in hot soapy water, boiling water every night, and sterilized so that we can knock down any hitchhikers that remain on the nipples that are accessible to the baby. So yeast can be sort of a head-to-toe situation, and certainly can be remedied very easily, but it takes a little bit of work, and it takes a knowledge of recognizing it and then bringing it to your healthcare provider's attention. And we can usually get these nipped in the bud pretty quickly. Next slide, please. Okay, pacifier drool rash. Well, a lot of our babies love pacifiers. Sometimes their pacifiers are their own fingers. Sometimes they're all the little wonderful goodies that we give them to try to calm them down, because they do love to suck, and it's a very primitive and wonderful calming mechanism for our little guys. But as you can see with that pacifier on the right, that thing is stuck like glue to that baby's face, and there's very little air movement between a baby's skin and that pacifier. So, of course, as babies suck, they drool, and so their saliva with all of its little bacteria and enzymes can get out and collect underneath that little gutter of a pacifier, and before you know it, baby's got a little rash on their chin like that cutie on the left. These rashes are really more cosmetic than anything, and even a baby who doesn't use a pacifier or have their fingers in their mouth may just get a rash like this just from drooling, just from being excited, teething, all those things that create a lot of salivary flow in babies. But every once in a while these rashes get a little out of hand. They get very red. They sometimes can get cracked and very uncomfortable, and so we want to do a few things to try to prevent them if they seem to be a problem. One is, if you can minimize pacifier use, if your baby will tolerate it, that's a good idea. Keeping that pacifier clean, washing it with soap and water, just plain old soap and water, not hand sanitizer, which is high in alcohol, but just plain old soap and water. Having a supply of clean ones around is reasonable. And then keeping some washcloths around with a little soap and water for your baby's face, wiping it down and cleaning it a few times a day is reasonable. And if all else fails, we've used everything from chapstick to diaper cream around baby's oral area. If you rub it in deeply, it's not going to be ingested, and often that will give you just enough of a barrier between that pacifier and the mouth to keep those rashes from becoming hugely red or hugely serious. It's an ongoing challenge, but again, babies don't have pacifiers forever, and these things generally don't scar. They're a bit of a bother, but baby's happy in the meantime.
Can I ask a quick question,
Sure.
Dr. JJ? And this is coming from the audience as well. Is this also apply to the rash that you sometimes see around the folds of the neck in a baby?
Definitely, and those, I mean, the principles are the same. You get breast milk or formula leaking down in there. You've got a baby with no neck because they don't really get a neck till after their first birthday. So this head on shoulders posture of a newborn, it's basically a little sink trap down there for milk, for sweat, and also for dead skin cells, because when you're bathing a baby and as they're getting their little Michelin folds and getting so voluptuous and delicious by the time they're 3 or 4 months of age, you can smell cheese on these babies. I mean, if you lift up their chin and you've forgotten to wash there after a couple of days, there's a lot of red, moist yuck that you can find there under their armpits, under their little scrotums, wherever you sort of forgot to lift and separate. So it's really, really a good idea when you're bathing your baby to literally with your fingers lift their chin, pry apart their skin, get in there with dry cloths and wash if they've appeared to drool, and try to keep those areas as dry as possible. And it is a challenge because our babies are like Shar-Peis by the time they're 4 or 5 months of age, and so we often sometimes miss those areas, and before you know it, you've got a red hot mess in the neck folds. So what do you do for those? We typically don't like to shake powder around a baby's airway because they can ingest the talc or the cornstarch that's in the powder. But if you've got either a loose baby powder or a liquid powder like we make, what you can do is dip your fingers in or dip a little cotton ball in the powder, separate the neck folds, wash them off first and dry them, and then apply a little cornstarch powder or absorbent liquid powder in those areas to keep them dry, and generally that will clear up those areas. If they're super red like that candidal diaper rash and they don't clear after 2 or 3 days, reasonable to check with your doctor because sometimes babies can get yeast in those little folds as well, and sometimes a little Lotrimin does a good job there too. So that can be a stubborn area and kind of a surprise to parents, and we're so busy looking at our gorgeous, scrumptious babies, we forget that they can grow cheese in their folds, so buyer beware. Next slide, please. This is fun. It's like being in the office. It's great. Okay, probably what most of you are concerned about is this poor little baby up here. Eczema is a condition of the skin that is also called atopic dermatitis. It is a marker for potential allergies in kids, and I say potential with a caveat here because some babies will get eczema early in their life when their immune system is immature and incapable of recognizing who's friend and who's enemy. And by 2, 3, 4 years of age, a lot of kids will outgrow it. So it may be a temporary condition in some babies, but it may be lifelong in others. And so recognizing eczema is really an important thing because there are some things we can do for it. It is, we call it the itch that rashes. And what happens in babies or children of any age is that their skin has a basic defect. The actual cells of the epidermis are kind of like small tiles on a tile floor. And normally our healthy skin will have grout between the tiles connecting each of those to each other so that if there's something underneath the tile, it can't evaporate through the grout. That's healthy skin. Now skin that has eczema or atopic disposition is kind of missing that grout. So those bridges between the cells that retain moisture and help keep natural skin oils in really let it all out. And so babies' and kids' skin tends to dry out quicker. It tends to start itching because the local environment is rich with histamine, and before you know it, baby is clawing at their skin or rubbing it on anything that they can find. And before you know it, it's the itch that rashes, and this poor little baby with their face full of red, scaly discomfort becomes apparent. Babies who have eczema generally aren't going to be very happy at times because they can have very widespread distribution of this, often on the face, on the back, and in the early days of infancy, on the backs of the arms and legs are very common places to find it. It can be found on the hands and feet or any place where there's occlusion or friction, so around their little cute trumpet socks or their little baby jewelry on their wrist or wherever there's a nickel snap on their onesie, sometimes under metals or just under conditions where they're rubbing their face on mom's mohair sweater or a woolly blanket. Any of those things can aggravate or promote the appearance of eczema. But most importantly, in the newborn period, when kids aren't eating a host of foods and we're not putting a whole lot of things on their body, typically, food can be the culprit. So if a baby is breastfeeding, it's important to recognize that if eczema comes up in these early days, that there is something that potentially can be done. There's the top allergens in mom's milk that can be responsible for eczema are typically cow's milk and eggs as sort of the number 1, 2 in a close tie, then soy, wheat, peanuts, and fish. And so your doctor, if he or she sees eczema in your baby who's breastfed, may first question, what are you putting on the baby's skin? Are you putting on anything that's not hypoallergenic or meant for sensitive skin? And if the environmental inquisition doesn't yield anything, then food is really going to be the next place to maybe intervene. And so elimination diets where you eliminate one of these allergens for about 2 weeks to see if it results in improvement of your baby's skin can really make a huge difference in this eczema in these early days. So a baby typically with eczema may have a genetic predisposition, especially if he's looking at mom and dad with itchy skin or asthma or seasonal allergies. This allergy gene may express itself in different ways, and so a baby may have eczema and later on in life have hay fever or asthma or none of them, but just have eczema in their early days. So the genetic predisposition certainly can be there. The allergy or to a component of mom's milk or a component of formula may be the trigger. And so if a baby is formula fed, your doctor may switch you from a milk-based or soy-based formula to one of the hypoallergenic formulas that have neither milk nor soy, because 40% of babies allergic to milk have sensitivity to soy as well. So if your doctor says, let's try some Nutramigen or Alimentum or Enfamil AA or a big elimination diet for mom who's breastfeeding, those are reasonable interventions, and they may make the difference between a baby whose skin is itchy and uncomfortable and a baby whose skin is clear and not in need of any medications. So this itch that rashes is really one where we can really do our babies a favor by being detectives, being proactive, really examining our own habits and working with our doctors as a team to try to get the skin under control. Now, why do we care about eczema? Well, it can be very widespread in a baby, and certainly we don't want our babies uncomfortable, but the areas of the skin that have eczema involved with them are also broken areas. So there is a lot of leakiness in the skin. There's a lot of portals to entry for bacteria. There's a lot of areas where babies can leak fluid and nutrients through this really, really highly inflamed skin. So we really want to get it under control so that we don't get secondary infections with skin bacteria, and we don't want to have to use a lot of medical interventions in babies if we can clear it up with dietary or environmental interventions. Now, if eczema does get very severe and red and inflamed, your doctor most likely will recommend the application of a topical steroid or anti-inflammatory cream to these areas for a short period of time to try to reduce some of the inflammation and knock back some of the itch and scratch so that skin has a chance to heal. And in this little drawing here, you see on the right that those skin bridges are really leaky and leaking all sorts of inflammatory material, whereas the intact tiled flora on the left looks nice and healthy and pink. So we want to really look in infants, look into dietary interventions with our doctors. With our babies, we want to look at also their local environment, what they're wearing, what they're bathing in, what others around them are wearing as well, because babies are up against our skin, and if we have big perfumes on our skin or we're wearing really woolly or irritating clothing, that could be just the reason why babies' skin is rashing. And in older babies and tots, allergy testing may be useful because, again, they're out there in the world exposed to much, much more than our infants. And if there are environmental things like animals or feathers or dust or other things that they encounter in their daily travels at ground zero, sometimes allergy testing can help us sort that out. Next slide, please. Cindy, you're doing a great job reading my mind, too. Okay, so the principles for eczema is that if we can identify an offending agent, we're going to try to eliminate that offending agent. Now, this time of year back in the East Coast, an offending agent may be something as simple as the very dry heat in the house, and it's so freezing outside and so dry inside as we try to warm up. So keeping skin plump, hydrated, and restoring some of its natural moisture that's been lost through those leaky bridges or lack of bridges is really key. So we want to use cleansers in the bath instead of soaps, because soaps can strip skin of its natural oils. We want to make sure when we bathe our kids that they're not in ice water, but we don't want to put them in too hot of water for too long, because hot water can strip skin of its natural oils as well. And we want to rinse them thoroughly, and especially if you're using different products on your skin, you want to rinse shampoo off their skin, because shampoo sometimes may not be as gentle as a cleanser that you use on their body. And so if you can use a gentle cleanser head to toe, that's always advisable. And within 30 to 60 seconds of getting out of the bath, if you just pat the skin dry very quickly and not fully, leave a little mantle of moisture on the skin, and then just smear your kid down with a really, really good rich emollient. That's going to be a great way to seal in that moisture and sort of provide a little grout for baby skin. So you should look for ingredients that are rich in oil, so if something has grapeseed oil, avocado oil, olive oil, antioxidants, shea butter, those are wonderful things that mimic skin's natural barrier. And there's new generations of things called ceramides that also mimic some of the sphingomyelins in the skin, and they're terrific products as well. If you go to NEA, nationaleczema.org, this is an organization 4 million strong, and their panel of experts vet products and examine them very closely to approve ingredients that they feel are compatible with kids and adults with eczema. So it's a great resource. There's a whole library of information there too. So I just wanted to insert that because I think they're a terrific organization. They really are advocates for trying to help identify safe products for kids. And the most important thing, and this is new science that's kind of coming out, is that you have to really look at ingredients of what you're putting on your kid's skin. And although we love natural and organic, try to avoid nut oils in kids with eczema. You don't want to put macadamia or almond or peanut oils on skin because the absorption through the skin is thought to sensitize them for later allergies, and it's thought to be much more important than ingestion or inhalation. So if you can't see those ingredients on a label and your kid is really suffering from eczema, go on the product's website and really look deeper into their ingredient list to make sure that you're not making that mistake. Ironically, one of the most commonly used eczema oils with steroids in it has nut oil in it, and it was just quite a surprise a few years ago to find out that what we thought was great to use on a kid with eczema skin contains something that may have perpetuated it. So really good to just be, again, an advocate and proactive for your child's eczema, because this is an important problem. Next one, please.
I'm sorry, Dr. JJ, a basic question just came in. What do you mean by emollient?
Emollients are, okay, emollients help preserve skin moisture. So if something makes your skin shiny and oily, it's more likely to mimic the bridges between cells than something that's a lotion that absorbs and is meant to evaporate. So a thin lotion makes us feel soft for a few moments, but in a kid who has super dry skin, who's really inflamed, may not do the trick in terms of giving a long, sustained effect of holding moisture in. So the thicker and the more oily the balm or emollient, the more likely it is to hold that moisture in for longer periods of time. That's a great question. Thank you. Okay, next slide. Okay. We're going to get to some viral things here because in the first year of life, this little child here looks like they went through a little paint sprayer, is showing the rash of something called Roseola. This is thought to be a human herpes virus. It doesn't cause herpes like we know it with cold sores or genital herpes. It's a distant relative, but it is a virus that's thought to be spread pretty easily by either respiratory or contact spread. We're still not quite sure how. It commonly spreads in baby classes and daycare, and so for those of you who are in Mommies and Me's or have your kids in daycare with corporate daycare, Roseola may show its head several times during the year. It's a viral illness. There's no antibiotic that makes it go away. The incubation period is usually about a week to 10 days. And typically a baby is the victim. Most kids we see with Roseola are under 1, so it's important to know what this rash looks like. Babies generally will have a pretty sudden onset of high fever lasting 3 to 5 days, and fever meaning 101 to sometimes 105. They are irritable as all get out, and often your doctor will not be able to find the source of the fever. Sometimes their ears look a little red. Sometimes their throat might look a little red. They might have a little loose poop, but you really can't hang your hat on why that fever is so high. But a couple things we see on exam that sometimes give us a clue that Roseola is there is the lymph nodes behind the ears on the hard part of the scalp sometimes pop up, and so you feel a couple little things back there that feel like kernels of corn or lima beans. That's always a good sign that this may be Roseola. Or that the eyelids may look a little puffy, especially in the morning. So if baby looks like they've been out all night partying down and they've got a couple little bumps behind their ears and a high fever, chances are they're going to have Roseola. About 70% of these kids, when the fever goes down, the rash will come. 30% of them don't get the rash, but they all act irritable for a couple days even after the fever goes away. So your doctor, chances are they'll walk you through this process. They may want a blood or a urine test because they can't find the cause of the fever. But when that rash comes, boy, it's a real it's a game changer for everyone because there's a sigh of relief. And even though baby is fussy for a couple more days, that rash just signifies that they've just been through this viral illness. And typically only babies only get this one once. So here's the deal. It's fever for many days, and at the end of the illness when the fever goes down, that's when this rash comes. And this sets us aside from other viral illnesses where rashes come at the beginning or the middle, but not the end. So what do? You try to keep baby comfortable. You don't need to chase every degree of fever, but keeping them comfortable by giving them whatever your healthcare provider recommends, whether it's ibuprofen or acetaminophen, plenty of fluids and a lot of moral support for yourself, and a little bit of patience, and then a lot of relief once the fever breaks. So that's Roseola.
Great.
Next slide.
I'm going to have you go through these last three kind of quickly so we can just get to questions before we're out of time.
Passed so quickly. Okay. Impetigo, in a nutshell, is staph or strep, lives on top of the skin normally, but when it crawls under the covers, it can cause a little bit of a inflammation in the skin. And so typically a baby, for example here, has had a cold, their nose is running, and all of a sudden they get these crusty, almost little blistery lesions around the nose or mouth or chin in the pathway of the nasal mucus. This is a typical case of impetigo. Can also happen when kids scratch things like abrasions or bug bites. And why is it important? Well, strep and staph, if they get in the little underground underneath the skin, can also get into the bloodstream and on rare occasions cause fevers and spread of bacteria through the blood and also some kidney inflammation. So if you saw these little things around the level of the nose or on the baby's body and put a little Neosporin for a couple of days and they seem to progress and show up elsewhere, reasonable to get to your doctor because at that point they would need something typically like an oral antibiotic and a full course, almost like for a strep throat, to get rid of the risk and also keep the impetigo from being contagious because this particular rash is very contagious with direct contact. Next slide, chickenpox. We're not seeing so much anymore because we're immunizing kids at a year of age, and if mom is immune and had chickenpox as a kid, her IgG or her natural immunity coming over the umbilical cord usually protects the kids in the first year of life. Why do we worry about chickenpox? Well, in this era of supernova bacteria on our skin and methicillin-resistant staph, we have a few kids in this country every year who really suffer and sometimes even die from severe cases of chickenpox that go wrong with secondary bacterial infections. So we really advocate the use of chickenpox vaccine for our young ones, especially if they have any kind of health conditions that put them at greater risk, like leukemias or immune deficits or severe eczema or severe other skin conditions whereby chickenpox might really complicate matters. The symptoms will be on your slides here, and the key thing for chickenpox, if you do have kids with it, is to keep their skin very clean. They should bathe once or twice a day with soap and water. Topical calamine or Aveeno-Baz are great to ease the itch so that they're not scratching the lesions open. Oral Benadryl is helpful to keep those little fingers from opening these areas, and keeping them in light, loose clothing so that they're not just crawling out of their skin are important interventions. One thing I should mention is to avoid the use of ibuprofen if your child does have chickenpox. In a few little studies, it was shown to contribute to risk for flesh-eating bacteria and other deep-seated secondary infections. So stick with acetaminophen if your child is not allergic, and talk with your healthcare provider if there are issues there. Next slide. And contact dermatitis, in a nutshell, this is red inflammation on the skin, usually caused by something that you might be allergic to. So in a baby, it typically might be a piece of jewelry, a little necklace that someone has given them, a pair of pierced earrings that are not pure gold, that might have a little nickel in them that might inflame an ear area, a little necklace, again, that isn't of the purest content that may leave its exact impression on the skin, or in my son's case, it was the snaps on his onesie that gave him this row of dots down the middle of his belly because he was sensitive to the metals there. So often contact dermatitis is a very easy thing to identify because the shape of the offending object or the location is generally easy to sort out, and so avoidance is the key. And if there's leftover rash, typically we use over-the-counter hydrocortisone 2 or 3 times a day to settle down that inflammation, take away the offending agent, and if it doesn't improve, then of course you're going to want to bring your child to their healthcare provider to intervene a little bit more aggressively. Next slide. I think that's it.
And that brings us to questions.
That was like speed dating with skin.
That was so great. Thank you so much for all of that amazing information. We've got quite a few questions that have come in, a lot of questions, as you can imagine, around eczema. And I'm going to try and summarize some of them so we can sort of hit a few at once.
Sure.
But we've had a number of questions come in about treatments for eczema, particularly some of the different treatments like hydrocortisone, hydrolatum, and aquaphor. Mm-hmm. And just if you could speak to some of those treatments and, sure. You know, are they safe? You know, are they recommended? That sort of thing.
Okay, so if we've tried to remove offending agents and we're left still with red, scaly skin, which means inflammation is present, you want to calm the inflammation first, because just putting hydrolatum or aquaphor on red inflamed skin is not going to get that inflammation cut down. So the first thing to do is try to cut down the inflammation with hydrocortisone or whatever preparation your healthcare provider recommends. Then, once the redness is gone, then it's up to us to use our hydrolatum, our aquaphor, our rich emollients, and our multiple daily applications to keep that skin happy after the inflammation is gone. So it's really key to attack the redness, and then after the redness is gone, to then keep that skin as itch-free, as plump, and as moist as possible. In kids who are prone to secondary infections with their eczema, there's new studies that show that bathing them in a bleach bath, believe it or not, a couple times a week, may help cut down on their bacterial skin infections. So what that means is basically about a quarter cup of bleach in a full tub of water, akin to a freshly chlorinated swimming pool, because chlorine has antibacterial properties. But that's generally going to be used in kids with recurrent infections and not kids with just mild little patchy eczema. So definitely check with your doc on that one.
Okay. We have another question here about a condition you actually didn't address. She's wanting to know how to care for hyperkeratosis pilaris.
Okay.
I hope I'm saying that right.
Okay, so for all of you who have Western, European, Irish, English, Swedish, Scottish, German roots like me, this is the curse of Western Europe. This is a rash that when you're an adult shows up as sort of this dry, bumpy chicken skin on the back of your upper arms. But when you're a young child and your immune system can't contain it there, it often will appear on the cheeks, on the fronts of the thighs, and on the arms as well. This is a genetic skin type, and this is a tough one because it's really with you for life. Sometimes if we rub it too hard thinking that we can exfoliate it with a loofah, we actually stimulate the skin cells more and make it worse. And the defect here is that if you look under a microscope, the keratin, or the skin protein cells, are about 5 times thicker around each hair follicle, giving us this chicken skin appearance. So in the early days when baby is young, moisturizing that skin frequently during the day, like you would with eczema, will keep that skin plump and moist and keep your baby from scratching and aggravating it. When babies are older and older children, sometimes we use preparations with urea or lactic acid to try to beat down those layers of keratin a bit, and dermatologists make a good living trying to get that skin a little bit smoother on the upper arms. But it's harmless. It doesn't scar. It worsens during puberty, so it is a distressing thing for our adolescents and pre-adolescents. But it is really sort of the mark of where you come from, and it's a badge of courage just to be worn proudly, but it can be moisturized down to a better level.
I wear it proudly myself.
I do too.
Now I know what it's called. Another question has come in about bathing baby and how frequently you recommend bathing baby.
Well, I think in the first couple of weeks, probably every 3 or 4 days or so, because babies aren't really rolling around in a mud pit, and they don't really get very stinky at that point. So sponge baths until their cord falls off or their circumcision heals are reasonable. Once babies are a little bit older, they really love being in the water. It kind of reminds them of the womb, and they love to splash and play. And so a baby can bathe every day. You don't necessarily have to use soap or cleanser with each submersion into water, but because that warm water will potentially dry skin, it's important to moisturize after, whether you're using cleanser or not. So it just depends on the baby's threshold. If the baby really loves it, daily baths are just part of a wonderful ritual you can have with your baby. And if they absolutely hate it, probably twice a week, 3 times a week is reasonable. Get in, get out, get the job done, and then moisturize.
And someone is asking what you recommend for eczema as far as a moisturizer is concerned.
You can use things as simple as grapeseed oil, avocado oil, just straight out of the bottle. I've had many parents use that. Albaline cream, believe it or not, is a wonderful old-fashioned, almost cold cream-like preparation. Dermatologists love it. Cetaphil or some of the hypoallergenic ointments or creams are reasonable. And the key thing is to keep away from things that aren't tested. You really want hypoallergenic products. You want products rich in oil. So the thicker, generally, the better. But if they're too thick and too oily, as babies get older, they'll run away from you because they don't like the aesthetic of too much goop on their skin. So sometimes balms will be more better accepted than a really oily Aquaphor or Vaseline, but in a pinch, those things will always do. And in the South, they use Crisco, believe it or not. It's cheap, it's accessible, and it does a great job. So there are a number of things out there that can do a great job. And if you go to the National Eczema website, there's a huge, huge list of wonderful recommended products.
Thank you so much. And you must have been peeking into my house when you talked about a child running away from you. Running away from the emollient.
They run away from us in the office. they run away in our own homes, and so it's just to find things that your kid will let you put on is probably the greatest mark of parental success, especially if they have a chronic skin condition, and that includes sunscreen as well. So just remember out there, unless it is torrentially raining, that UV protection is important year-round, and especially with you guys having snow back there, you get reflection off of buildings, off of snow, and kids can get some pretty wicked UV damage during the winter. So don't forget your sunscreen. Even with those teeny little bits of faces exposed, they still need a little coating every day.
That's a great reminder. Yeah. Thank you so much. Yeah. Well, and unfortunately, we've come to the end of the hour.
I wish I could say hello to all of you face-to-face, but feel free to come to our MD Moms website and ask questions anytime, and we're happy to help, and we always post useful tidbits as well, and we work very closely with ISIS to provide those on your end too. So it's just been such a pleasure to hopefully provide some insight and some help to all of you this evening.
Great, and I passed along the link to all of our MD Moms products, which right now we're offering free shipping in our online store, so that's really exciting, so you can get it straight to your door. We'll also be providing, when I email everyone with the link to the recording, I'm also going to provide a list of those links, some of those websites that Dr. JJ recommended, any of the products that she recommended. I'm going to try and get those all on paper for you so that you can have that information, because sometimes it's a little hard to follow when you're following along here on the webinar. So thank you so much, Dr. JJ, for sharing this valuable information with us. And thanks to everyone for attending. You'll be hearing from us probably early next week with that recording. So thanks again.
Thank you, and have a great weekend, everyone. And just let us know if you have any more questions, okay? Good night.
Okay, thank you. Bye-bye.
Bye-bye.